I'd like to welcome everyone to this Translational Applications in Public Health lecture, which is a collaboration between the Institute for Public Health and Medicine, IFAM, and the Northwestern University Clinical and Translational Sciences, NUCATS Institute. I'm Darius Tandon. I direct the Center for Community Health here at Northwestern. I want to thank everyone for joining us, and importantly, during the presentation today, for those of you who are joining remotely, please use the Q&A function instead of the chat to submit any questions you have. Today's presenter is Dr. Marquita Lewis-Thames, who is an assistant professor in the Department of Medical Social Sciences and also core faculty in the Center for Community Health. She received her master's in public health and PhD from the University of Alabama at Birmingham and did postdoctoral training at Washington University in the area of cancer disparities. She is quite simply an amazing community engaged researcher and is doing remarkable work in the area of cancer and other health disparities, particularly in rural populations, and is currently being supported by a K01 from the National Cancer Institute. It's my pleasure to welcome Marquita.
Well, thank you, Darius. That was very, very, very kind of you. And I am really excited to be with you all today. I will say that I tend to walk around. So if you get a little dizzy, just pay attention to the slide, it will be fine. So I'm talking today about truly my passion, which is rural health. And those determinants of health that I believe are very important for us to advance rural health. My advancing button doesn't work. Let's try this way. Nah, that's unfortunate. Okay. What am I trying to do? Oh, there we go. Do we have? Oh, it started working. Okay, hold on. But wait a minute. It's still going. Okay, cool. All right. So I'm part of a generation of young people, 80s babies, 90s kids, who were influenced by the masterminds that you see in front of me. Okay. I was influenced by their inquiry, by their diplomatic diplomacy, and learned after every episode when he would say, "Gee, Brain, what are we going to do tonight?" And Brain would say, "The same thing we do every night. We try to take over the world." Now, I show you Pinky and the Brain because that is actually my agenda for today. My goal for you today is to try to take over the world and let everybody know that rural health needs to be advanced. And so we don't leave today with that agenda in mind. And clearly I didn't learn what I need to learn from Pinky and Brain. Now, you may ask the question, why is this young woman, this amazingly beautiful young woman in Chicago talking about rural health? And I often say very quickly that my rural health education began at my grandmother's kitchen table in rural, historically segregated Dorchester County, South Carolina. And as I was reaching over pound cake, and as I was reaching over macaroni and cheese, where people would say, "Oh, I'm not going to go to that hospital because they experiment on lactose." Or, "Oh, I'm not going to go to that hospital because every time I go to the hospital, they always say, I go to the hospital, put on me." And I didn't necessarily know they were talking about medical distress. I didn't necessarily know that they were talking about multiple comorbidities. But as I advanced through my degrees, those conversations became the anchor for the work that I do today. And so I actually describe the work that I do as community to clinic care coordination. So individuals like myself, in order to go to the doctor, all I have to do is leave home, leave my community, and shower on parts outside. Go to the doctor, but I need to. However, for rural residents, there are determinants that have to be influenced, that have to be considered in the community and in the clinic when we're talking about that care coordination. And I'm talking about those community as well as those, community as well as those individual level determinants. So while I was preparing for this presentation, I was reading some transcripts. I am a qualitative researcher. I was reading some transcripts, and this was just so juicy, I couldn't pass it up. So one of the participants in the study that I'm looking at, this study is actually looking at telehealth navigation and barriers and facilitators for rural health.
Oh, I think that somehow that one's in, and I think, yeah, sorry.
Let's try, because I don't want to interrupt anybody. I mean, I don't want to keep the experience from anybody. Can they hear me now? Can you hear me now? I feel like an old, like Verizon wireless commercial. Fantastic. Anybody who got the Pinky and Brain will also know the old Verizon wireless commercials. Means I got to be still. All right. So going back to it. It's a flipping nightmare. But knowing what I know and what hospitals I have been associated with, I'd be more comfortable if we went to someone with a specialist. And a lot of people don't have that kind of access to people that because they don't have the insurance. They don't have the ability to get there, and they don't have any rides. So this participant was really very illustratively showing us those determinants for that community to care coordination that I'm emphasizing. So any rural health researcher has to start off a presentation about griping on the actual definitions of rural health. There are like 15 different definitions of rural health. There's some combination of how close you are to an urban center, or how long does it take, or even how many people are in your community. So I'm going to give you an example of some of our contentions. So if you look on the left-hand side, US Census Bureau basically identifies anything in yellow as rural. But the Office of Management and Budget also identifies anything in yellow rural. As you can see, Grundy, Kankakee, and Kendall counties are considered rural according to the US Census, but also considered metro according to the Office of Management and Budget. If you've ever been to Grundy County, there is nothing rural out there. So these are some of the challenges that we face in rural. But oftentimes when I say the word rural, this is what you think about. This is Iowa, Wisconsin. This is the place that makes cows happy, okay? Happy cows live here. But rural America is very, very geographically and sociodemographically diverse. All of the green that you see there are identified as rural areas. And so this is rural. Rural is more than our happy cows, but rural includes the mountains. Rural includes the deep south. Rural includes the northeast of Maine. Rural also includes the southwest. It is also racially and ethnically diverse. So we have many different populations that are many racial and ethnic groups, as well as sexual and gender minority groups who live in our rural areas. This map is from a colleague of mine, Whitney Zahn, who is in University of Iowa. She is amazing, follow her stuff, giving her many props. She actually identified groups of racial and ethnic areas along in the United States where we have more than 20% of that racial and ethnic group. So on the lower southeast, where you expect the deep south to be, that is more than 20% African-American in that rural community, in those rural counties. That's the orange area. The pink area, we're looking at more than 20% rural, of the rural population are American Indian Native, American Indian Indigenous folks. We're also seeing areas where a lot of that green is where more than 80% of that population is white. So I do want to point out that the racial and ethnic composition across the United States is very diverse. And speaking of these racial and ethnic groups, I want to point out what's called the Mississippi Delta Valley region. So the Mississippi Delta Valley region is an area where you see that orange and that green meets. So we're seeing an area where we have communities where it's over 20% Black. We're also seeing communities where we're having over 80% white, all right? Now, this area actually extends from lower Illinois down the Mississippi, so you're going past the Appalachian, through the Appalachian, all the way down to Louisiana, Mississippi, and parts of Alabama. Residents in the MDR are often characterized with poor health outcomes. So we're looking at higher smoking rates, obesity, hypertension, higher rates of diabetes. They're also characterized by low screening behaviors. Darius mentioned that my research focuses on cancer outcomes. And so I'm showing you here that on our x-axis, we're actually looking at increasing rurality. So on the side where it says 1, that's of Chicago. On the side where it says 9 on our x-axis, that's that community that doesn't have a name on your Google Maps that's buried between massive just expansion, okay? On our x-axis, on our y-axis, we're looking at the number of the cases of cancer burden. As you can see, as you get more rural, there is a slight increase in our cancer burden. In addition to that, we have an example of what's called a colorectal cancer hotspot map. So in the colorectal cancer hotspot map, we see that number 1 is that Mississippi Delta Valley region that I was telling you about. A hotspot is an area that has a high cancer mortality. In this case, we're talking about colorectal cancer. So both white and Black rural residents have lower screening rates in this area than their urban counterparts. However, rural Black residents, it has been found that they have a actually lower cancer risk in this area. So compared to their urban Black counterparts. These studies also suggest that health outcomes related to race may be different by our rural and urban regions. So the reason why we may actually see these differences between our rural urban regions and our racial and ethnic groups is determinants of health. That is literally what this whole conversation is about. So looking at these determinants of health include conditions and places where people live, work, learn, play. As we're looking at the Healthy People 2030 diagram of determinants of health, you see that there are representations of individual determinants of health, but also there are those representations of community level determinants of health. Another example of this interplay of individual and community determinants of health, we see that a study cited by the National Academy of Medicine found that medical care by itself only included about 10 to 20% of the contributors to health outcomes. The great majority of contributors to our health outcomes come from our social determinants of health. I also want to say, if you have any questions in the room, feel free to raise your hand. It's cool. It will be wonderful. I'll repeat the question. I'm going to give you a very jarring example of this interplay of the community level and individual level of determinants. So Anna, Illinois, once again, that expansion in the middle of, your Google Maps is super nothing there, no name, Anna, Illinois. This is actually at the bottom of that Mississippi Delta Valley region that I told you about. That's in the Southern Illinois area. So Anna, Illinois, I've done some research, qualitative assessments in Anna and learned some things there. One of the things that I learned is that Anna, Illinois is a sundown town. To this day, people actually recognize it or at least understand its history as a sundown town. For those who don't know what a sundown town is an area where after dark, at a point in time, if you were a Black person, you would get victimized. To be more explicit, you would be lynched, okay? It is known as a sundown town. I wrote it as an acronym because it is still known to this day as Ain't No N-Words Allowed. All right, take that in. Remember the conversation I told you I had in South Carolina where folks would come into the house and say, no, I don't go there because they're experimenting on Black folks. Remember when I talked about that? Think about the Black residents that are here in Anna. The Black residents whose grandparents told them, I can't go to a hospital here in my own community because the very same doctors, the very same administrators, the very same politicians are participating in these sundown activities. These are community level determinants that impact your individual behavior. So that brings me to my next issue that I want to talk about, which is rural residential segregation. Remember, I started talking about that colorectal cancer hotspotting, saying that, hey, Black folks, rural Black folks, had a lower risk of colorectal cancer. And we're asking the question, well, how does that happen? So a group of researchers and myself decided to look at rural residential segregation as a determinant of health, as a community level determinant of health. Now, despite declines in metropolitan areas, we are actually seeing an increase of rural residential segregation in our rural areas. Rural residential segregation has been linked to multiple negative outcomes, including poor cardiovascular health, infant mortality rate, higher obesity, and so forth. The largely rural MDR, which is about 252 rural counties, the largely rural MDR is heavily segregated. So it made it a really good area to begin to look at the impact of what does rural residential segregation have on our health outcomes. Now, for colorectal cancer, rural residential segregation might be linked to this Black and white disparity that I told you between rural and urban counties. Going back to my map again, to date, there are very few studies that are looking at rural residential segregation between rural and urban communities. So we looked into actually investigating what is the interaction between rural residential segregation on colorectal cancer mortalities, and we use the MDR. As I mentioned to you, it's about 252 rural counties and 250 urban and rural counties in the MDR. And we actually did this by estimating two linear mixed effects regressions, as well as we calculated the multi-level index of dissimilarity, excuse me. What I want to point out here is one of our figures that we have from this study. So we're looking now at the interaction plot of the moderating effect of county rurality and its relationship to Black and white residential segregation. On my x-axis, you see that we have increasing Black and white segregation. So how much of the county is actually segregated? Is it more like 25% segregated versus 75% segregated? On my y-axis, I'm looking at the Black CRC colorectal cancer mortality rate, okay? So what we're seeing here that when we look at the interaction term by county rurality and segregation, there's a statistically significant, indicator that county rurality is a moderating effect of segregation of Blacks in rural counties. So if we're looking at this, the Black solid line is showing that as Black rural residents, and I also want to make sure that we're looking here at the Black colorectal mortality rate. So we're looking at Blacks who are less segregated. There's higher in rural, there is higher cancer mortality. But if we're looking at Blacks who are in urban areas that are less segregated, there's lower cancer mortality. Looking at this, kind of quantifying it again, I want to quantify that interaction. So looking at the top, forgive me, let me get some water. At the top, our model is showing Black CRC mortality as well as white CRC mortality. On the left-hand side, we see with the negative 12.21, we're seeing that actually as we're having more segregation, we're seeing less colorectal cancer risk. However, for our white residents who are in rural areas, as we have more segregation, we're actually seeing that there is more colorectal cancer mortality. So you may be asking, why are we seeing this? And I want to point it out. I'm not saying yay Jim Crow, okay? That's not at all what I'm saying. But what I am pointing out is when we're looking at our rural communities, there's probably a lot of nuances between our racial and ethnic groups that we have yet to explore. A lot of nuances to how folks in our rural areas, especially when they have very few access to resources, how are they living, thriving? What are those community determinant levels? What are those individual levels of determinant of health that influence this kind of interaction? Now, one thought is that racial and ethnic enclaves may have a health benefit for our rural residents. Let me take you back to Anna, Illinois, a rural county. For the Black folks in Anna, Illinois, they had to work hard to stay and live. And that might have actually benefited them as far as understanding how their health communication, and health knowledge today. Because of basically, I'm in an area that my whole entire environment, my community could hurt me. So as a community, we have to strengthen ourselves. I will also say that, I'm just going to throw this out here as well. I did work with a group of individuals here on, I worked with, we wrote a paper, focusing on personality traits, rural and urban differences in personality traits that were in the health and retirement survey. Now, this health and retirement survey was about 90% white. And the 5 personality traits include openness, conscientiousness, extroversion, agreeableness, and neuroticism. Now, I'm not going to dwell too much on this because I'm not saying personality is a determinant of health. There's not a lot of research that's actually even connecting personality, social connectedness, and health. But I will say in this research that we found that in our rural residents, there were lower levels of openness and conscientiousness and higher levels of neuroticism. So there's thoughts as far as what does it mean and what are those nuances? How are these personalities and how are the individuals in this community? What is that community personality what are the individuals in the community value that shapes their way in which they're connecting with one another? So there are some gaps in the literature that I want to point out. I didn't point out age differences, but we do see that there may be some differences when it comes to age and resilience in our communities. And what does that look like across rural urban areas? Also, other determinants to look at, to focus on, may be structural and historic racism and its impact on racial and ethnic groups within urban and rural spaces. Looking at, again, personality, and then also looking at other racial and ethnic groups. You remember the map and how colorful it is? What does that look like when we're looking at the ability for individuals and their health risk and social connectedness across our rural urban spaces? So I do want to point out, and I don't know if this is going to work. Of course not. That's okay. No worries. I do want to point out that I think community is a strength of all of our rural communities. It's a big strength. I don't know if anybody's ever seen this, but this is hilarious. This little TikTok or whatever it is Basically, this guy comes in and he's like, I want to learn a little bit more. I want to be part of this rural medicine. And he realized that the doctor is not only the pediatrician, the doctor is also the infectious disease doctor. The doctor also does heart surgery, and he's the mayor. Now, this is a true story that I'm going to give you. This is one that I actually experienced. So it doesn't have to do with rural medicine, but it does talk about many hands make the load light. So I was working in Alabama, was working with community health workers. We were having a meeting, right? And we were bringing community health workers from all over the state. So I had to find a centralized location to do this training. Just so you know, if you ever want to do something in a rural community, your event spaces are libraries, community colleges, and high schools, okay? You would think it would be churches. It depends. You got to know somebody. It's like you got to have an in. But so I called a high school. Went to the high school, talked to the principal. Actually, I didn't go there. I called them. Said, I would like to see if I can reserve space so that we can have community health workers talk about diabetes health. Principal was like, great. She said, I'll schedule it. I was like, excuse me? You do your school scheduling? Okay, cool. Do your thing. So she scheduled it. On the Friday before I go, I call up because the training was on Saturday. I call up and I ask, hey, I'm just letting you know, we're going to be here. Is everything okay? Talk to the principal. Principal said, absolutely. I'll meet you in the morning to open it. So you don't have a custodian that does this? Cool. All right, bet. So I'm really excited to meet this principal. She's so gregarious. She's so kind. She's so warming. So I meet the principal. She comes in. Oh yeah, and I forgot to mention, we're also serving food. So I meet her, she opens the door. She says, oh, the cafeteria lady's late, but I'll go ahead and start y'all on some coffee. You see where the story's going, right? So then lunchtime comes around, the cafeteria lady and the principal are serving us. I'm like, this woman is so phenomenal. We got to do something nice for her. So we decided we were going to get her some flowers. Cool, no big deal. I go to the Chamber of Commerce to find some flowers. Guess who's the mayor? This is not a lie, okay? The principal is also the mayor. So I bring up that little story to say, the burden of rural healthcare is very real. Many hands make the load light, and by definition, rural means there's not a lot of hands. So we see that 86% of all US counties that have persistent poverty, they're rural. 86%. Now, persistent poverty means that the population has been at the poverty line for more than 20 years. We also see that in our rural counties, 20% of the residents have less than a high school diploma. Now, since 2010, these numbers have actually been increasing. The US population is about 20% rural, but only 11% of the practicing physicians serve rural areas. We also see that in 80%, y'all, actually the number is 84.3, but it didn't fit with all those decimals to like geometrically fit on here. More than 80% of whole rural counties are a mental health professional shortage area. And since 2010, there have been massive closures of rural clinics and hospitals to actually impact and make a difference on these health outcomes. And so the project that I'm actually going to talk about here is looking at supportive care services in our cancer patients. So just to let you know, supportive care services are really those services that kind of help you with that community to care coordination. So that's those patient navigation, smoking cessation courses, genetic counseling. Those are the services that help individuals outside of the clinic so that they can manage and maintain their health. There's unequal distribution of these resources, just like we've seen, there's unequal distribution of access to care between rural and urban residents. And this may potentially lead to deserts of knowledge, as well as it will lead to potentially lead to the idea that rural residents may not use or even know how important these services are. So I looked into it. I looked into it with a group of folks actually with a group of folks who were looking at a Midwestern hospital. In our Midwestern hospital, they were actually trying to basically improve, had a assessment to identify ways to improve their services, okay? And we really kind of wanted to understand what services they used, and we also wanted to understand, were they important? So we looked at 14 different services. Again, smoking cessation, patient navigation, psychosocial, all of those 14 different services. And you can see that compared to urban folks, rural residents were less likely to use the services. And yes means any services. Yes, any services compared to none. And they were also less likely to think that the services were important. We also see, as we controlled for different variables, across all variables, rural residents were about half as less likely as the top one shows to use the supportive care services, and about half as less likely to perceive its importance. Now, remember, y'all, I said I'm focusing on community to care coordination. And so if rural residents, we're seeing here that rural residents are not using as well as realizing the importance of these services. So it brings up this idea called structural urbanism. And I'm using this from a researcher out of University of South Carolina, Jan Probst. Promise y'all she's the truth. She's amazing. And she coined this term. And basically it's looking at a bias towards large populations, hard population centers. And it's stemming from three factors. The idea that one, there's a market orientation of healthcare services which necessitates a critical mass in order so that, a critical mass of paying customers for services that are to continue and fund services. It's also saying that it is a public health focus on changing outcomes of populations that are distinctively based upon the large number. So we have funding structures that are catering to the populace. We have a public health crisis, a public health need that's catering to the populace. In addition to that, there's also, which is where my previous study focused on, there are also inefficiencies as well as inequities in our low population and our low and remote settings that translate into unequal funding and translate into unequal use. And so this structural urbanism is something to think about as far as our hospital closures and those that are not getting funded, those that are not getting the resources, and why so many of them are in risk of any kind of financial, of those financial resources. So there are gaps, again, in advancing our rural health agenda. Obviously policy, restructuring how we're funding our rural hospitals. But y'all, research funding needs to be reprioritized. We see that in RO1s, they're actually catering to the ends. They're catering to the large studies. I actually have a KO1, and I've seen other KO1 proposals where their pilot study is the same population as some of the towns that I've worked with. And so our research funding structures aren't even advancing the ideas in which we can learn more about rural health because they're catering to the populace. There's also a need for more than just clinically based research. Y'all, I just made it clear, there ain't no clinics there. How can we do clinical research trials when there's no clinics there? And if our funding structures are actually catering to those clinical clinical research trials, we're missing our rural communities that don't even have a clinic. Also, this is why I'm here today saying we need stronger relationships between our academic institutes and the actual rural communities, because the emphasis on change for rural populations will be within those communities, learning those nuances of the communities, learning about the people in those communities, and actually implementing research that is reciprocal, that is bi-directional, those community engaged and community based research projects. So there was a qualitative interview that I did, the one that I actually did in Anna, and I'm not going to go into the study itself, But I want to read to you some of the conclusions from the study. So basically, we are asking, what are your cancer care needs in rural Southern Illinois? Reason why we asked is because at the time I was at WashU redrew its cancer maps, its cancer catchment maps, found out, oh my goodness, our catchment is super duperly wide. We did not know it went and extended all the way to Southern Illinois. We need to learn about that. I proposed a project, they gave me some money, I did it. So some of the conclusions from this qualitative study was that healthcare navigation depended on social connectedness. I'm not making this up. Individual and community level determinants working together. We also identified that access to resources required a high level of self-management. Why did it require a high level of self-management? Because of those information gaps I told you about, those information deserts. Where are they getting the information from? We've also seen that there's not a lot of use of it and an understanding of the importance of these social services. And lastly, community organizations and healthcare facilities were key in improving health outcomes. So as researchers, if we're not engaging community organizations, we're not learning what those important healthcare outcomes are. This brings me to my final study. I'm not going to even talk about it because this is my KO1, which is the synergy study. Now, without going into too much detail, the study is actually trying to create a model in which we're using community as well as clinical representation to improve the survivorship care of rural residents. I hope I've made it clear why we need clinical and community working together. So basically, I'm using the chronic care model, which posits that if you have a community agent and a clinical agent, not magically, but through work, productive interactions, you'll see improvements in the health outcomes of the patient. I'm actually using community health workers for this. Now, if you remember the quote that I showed you earlier on, where the participant was talking about driving 2 hours to Chicago, right? It wouldn't make any sense if anybody came from Grundy, got their care in Chicago because they're specialists here, and for that social worker to know what's going on in Grundy. So what if we actually take individuals who are in the community, provisionally train them in what it means to help a survivor, and actually have a model where community health workers are working alongside with the clinical care team? And so the purpose of this study is to actually test the feasibility and the acceptability of the survivorship care team model that embeds community health workers and a clinical care team. Now, because this is a feasibility, acceptability trial, I know you're probably like, well, what's the overall health outcome? We're also looking at how can we improve that timely follow-up care? So those access to those supportive care needs. So I'm actually embedding this community clinic model in an implementation framework. So that's the arrows that you see. That's the EPIS model. We're going to provisionally train community health workers who are residents of rural counties of the survivors. We're also going to have the community health worker help with goal setting, communication, as well as identifying and assessing those supportive care needs. And that community health worker will work in tangent with the clinical team to hopefully we're going to see to improve that timely follow-up care. So this is an example of those community and individual level determinants that are important to advance rural health. I've given you a lot of gaps and where those gaps are, and I hope I've inspired you in your own respective areas of where those gaps are. Here's my next steps. So I'm also focusing on geographic and age digital equity, okay? What does that look like for our rural residents who don't have access to digital health? And if you think about it, if you don't have access to internet, you don't have access to jobs, you don't have access to your healthcare records, you don't have access to school. This is actually a true story. I had one county that during COVID, you stopped school. School was where the high-speed internet is. So how the freak you gonna teach these babies? So if you don't have internet, there's a dearth of inequities that will follow. In addition, multi-site trials, because look, I'm a product of NIH. NIH like ends. We gotta find a way. That is why my KO1 is embedded in implementation strategies. How can we actually implement this across, remember that map I showed you? demographically and socioeconomically diverse rural regions, because they're out there, and I can't just take something from Southern Illinois, Northern Illinois, and plop it in the deep South of Alabama. I'm going to continue my advocacy. I didn't even talk about my advocacy, but as a community engaged researcher, I work with my community-based organizations. I've helped them with grant funding. I've also helped them as far as reinstalling and getting services in their area that they need for those rural residents. And lastly, I know that I'm going to be bent towards workforce development, and that may sound diffuse, but we're talking about social determinants of health here, okay? So just focusing on those health outcomes is narrow-minded and myopic. If folks ain't got money in their pockets, how the frick they gonna travel to Chicago? So with that being said, I'd like to thank my funders, folks on my team, my mentors, all the amazing folks, collaborators. And last, okay, I have to give you this story. I told you my family from rural, historically segregated South Carolina. So November 8th, my father was running for Dorchester County Council, and he was way geeked because he got an endorsement from James Clyburn, y'all. He was so excited. My father didn't win, but I just want you to know I am still very connected to that rural community, emotionally, familially, as well as financially. And thank you for your time. I welcome any questions. Yeah. Oh, yes.
What's your dad's next steps?
He literally, yeah. So the question was, what's my dad's next step? So he literally was like, so are you coming home for Thanksgiving? Because I'm trying to take a break. He wanted to make sure he could take a break without me coming home. So yeah, he's going to sleep. Any other questions? Yes.
How do you fund the community health workers? Do they get their funding? Second question is, what is their difference from the home health nurses and home health services?
Absolutely. So the question was, one, how are the community health workers funded? And the second question is, how are they different than home health? So they are funded through money I put into as far as to contract them in the KO1. Now, here's the super amazing thing about that. So I don't know, there was this epidemic that that was going around called COVID. Are you familiar with it? So as a result, there was an explosion of community health workers to actually do contract tracing. In Illinois, there are agendas, reforms, policies that are trying to find ways in which we can actually move forward so that community health workers are sustainable models in our healthcare system. For many healthcare outcomes, community health workers are not billable, and that's a huge impediment. And so one of the things is that in my contract, I'm working with community health worker organizations. Literally, I had a conversation yesterday to see ways in which we can contract those who were used as contact tracers, those who have shown themselves to their muster in their community, but that funding has been dried up. So that's how they're being funded through the grant, and there's an abundance of them because of COVID. As far as how are they different than home health? Well, they're not billable. So oftentimes home health comes in maybe because of like palliative care, end of life care. And so that's how home health can be billable. In addition to that, home health is one of those extensions of the clinic, which is awesome. They serve a lot of rural communities. A lot of rural communities actually appreciate it. But we're talking about somebody who is trained, who may not have an affiliation with a hospital. So this is somebody who is, when I was in Alabama, it was one of the community health workers that I worked with was like the teacher, she was a retired teacher at the time, but she was like the teacher of like 4 or 5 participants. So we're talking about, you know, just the regular community members who are in your area, provisionally trained in the curriculum to being able to deliver this curriculum. Does that answer your question? So no degree required, no special training, but unfortunately, because it's not billable, it's not one of those things that's kind of guaranteed, or I won't say guaranteed, but it's easily accessible because you've entered a certain stage in your care. Yes.
How about coordination here, like getting those community health workers to connect patients that they're serving back to healthcare organizations? Or is it like, I guess, is it bi-directional or is it unidirectional? Like how do we like make that kind of like.
Yeah, I think that's a really good as well as layered question. So one of the things that we are working on in the development and the design is assessing supportive care needs that the community health worker would do. So supportive care needs, as I mentioned to you before, patient navigation, yada, yada, amen. But it also includes like assessing financial need. It also includes assessing, of course, psychosocial support. So if we find through that assessment, you know, there is a need for your, like you need connection to financial services, that individual who's part of that rural community is more likely to know what services are in the area that that health department offers, or what services in a neighboring county that offer. That will help with that coordination. So it's not the case of I'm going to physically take you by your hand or pick you on up, even though a lot of things happen in rural communities where you just say, you know, I'm sorry, instead of asking for permission in order to save people's lives. So I'm not going to say that folks aren't going to give a ride, but that's not anything that's required. But identifying what does it take to have that coordination in between your visits so that you can be prepared to do it. Does that make sense? So we're going to be addressing kind of those structural as well as those financial impediments to make sure you do have that continuous care coordination, so that we can address those, as well as even those knowledge barriers to know why it's important, why we need to prioritize this. Did I answer that question?
I just had a follow-up question.
Yes.
So then these community healthcare workers, what is their difference to like local social workers, and what might be the benefit of having community health workers as opposed to social workers? Because it sounds like they do a lot of
Mm-hmm. You know, that is one of the things that, you know, it's like, what's the difference between a patient navigator and a social worker and a community health worker? I think that that is very layered depending on where you're talking about, right? The other thing is to really say that a lot of our social workers are often tied to our health departments or our clinics. We ain't got no clinics. So that also limits the exposure to social workers, right? There are health departments in our counties, but even they're limited, right? And in addition to that, how do you know to get access to it? So that community health worker is somebody to help you get access to maybe that social worker. So the community health worker really is playing the role as a community navigator to the resources, not to take away what those resources are, but to actually make connections to the available resources and help our survivors think about what are the resources that they need in order to have that care coordination, that continuous care. Did that answer the question? And I'm gonna ask that. And his question was, if I didn't repeat, what's the difference between the community health worker and the social worker? Yes.
So we have a question online, and I think it's from your dad.
I was actually going to say that please don't ask questions, but go ahead.
Veterans Day is in a few days. A lot of vets are in rural communities. Could the VA help in this research and or funding?
So the VA, I think one of the, for lack of better words, I hope I'm okay to say this, one of the sexy things about VA is that they have the largest data set of, largest and diverse data set of patients. They're very, very challenging to get into if anybody's ever worked with VA data. So holla at your girl. That's all I'm gonna say.
We have another question from Shelley. Can you say more about the intersectionality of rurality, race, and age? I would guess that an older Black person in a rural area would have it worse than even other Black citizens in that rural area. Would you agree?
Right, and the answer is no. So that's why I didn't talk about age differences, because that's a whole nother thing. There's mixed evidence out there about this, right? But the research is leaning towards, when we're looking at like structural racism, and we're looking at those historic racism, there's age differences related to health outcomes. So we're seeing that older adults who've actually been like older adults and their association with structural racism and health behaviors, health outcomes, they're actually improved. And you would think because you've been in that environment a little bit longer, the level of trauma would actually have a worse impact on your health. So the evidence is mixed, but there's a culture of folks who are leaning towards resilience, and maybe even some of the research that I've talked about as far as with the colorectal cancer hotspot, where potentially those enclaves have actually been protective. But when you are younger folks, we're getting into an area of basically more economic diversity. And so they might have ventured out from home. They might have had opportunities to leave the nest, and they might have actually had opportunities where they had to make it and they were by themselves. And so that has affected their health because they're making it in a very different area when their parents and their grandparents had the support. They probably didn't have the money, but they had the support of that community. That's speculative, but that's why I didn't bring up the age difference one, because we do see differences by age, and that's a very good question. Yes.
We have another question from Robert. As we try to recruit more minorities into clinical trials, it would appear that we need to dedicate more resources to improving the social determinants of health situations of all patients, but especially those from underserved populations.
Can you repeat that? I'm sorry, I missed it.
Not really a question, it's more of a comment.
Okay.
As we try to recruit more minorities into clinical trials, it would appear that we need to dedicate more resources to improving the social determinants of health of all patients, but especially those from underserved populations.
I actually agree. And then I'm also going to add to that and step on a soapbox if I can. I feel that the efforts to address including minority or increasing minoritized populations in our clinical trials is just not enough. I think that, as I mentioned to you before, in rural South Carolina, you know, hearing folks across the kitchen table talk about, I don't go there because I feel like they're going to experiment on me. We're talking about generations in which we've had this conversation. And I do believe that to see any kind of major movement towards having minoritized backgrounds, minoritized populations in clinical trials, and to see that in our generation is myopic. If you've ever been brokenhearted, you know how long it takes to overcome that heartbreaking. So why are we expecting that if we throw a couple of dollars towards health disparities, towards a few programs, that within about 2-3 measurable years, we're going to see change in our clinical trials? We've got to do it deeper. We've got to be able to, as researchers, we've got to be able to say, hey, the needle's not going to move for a while. And we have got to do a type of reckoning with our communities and understand the years of racialized medicine that has been practiced in this country. And I don't think the needle can be moved without that reckoning. Thank you for opening up that soapbox for me. Any other questions? Thank you, I appreciate it.